Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up sessions. This particular module is cases on pregnant patients with complications, and this particular case will be on a patient with virological failure. So let's start with the very first visit. Our patient presents and we discover today she's pregnant. She's 18 weeks pregnant according to dates. She has no complaints, she has no other problems, and she tells you that she's been on ARVs for the last 2 years. So what has to happen at this visit today? And the most important thing is that this has to be the booking visit. We can't try and bring her back to another day where we might have more time, because there's a good chance she might not return for several weeks. So of course we're going to start off with good basic antenatal care, which will include your basic antenatal bloods, hemoglobin, RPR, RH, and starting your supplements. And then we need to do specific bloods regarding her HIV. And as she's on ARVs, the most important blood test you are going to do is the viral load. And it doesn't matter how long ago the last viral load had been done. It's essential that we need to know what her viral load is now that she's pregnant. We also need to make sure that her creatinine is up to date if she's on tenofovir-based regimen. And then two tests that's not so clear is the hepatitis B. In the PMTCT guidelines, it's not clearly noted, but it is certainly part of the adult HIV guidelines, where all patients whose HIV must have a baseline hepatitis B done. In a patient who is pregnant and who has a STI, which is what HIV is, I think it would be prudent to do an hepatitis B at this point. And a CD4 count can be done depending on whether the last CD4 has been done and whether it's clinically indicated. Very important for any patient with HIV, but even more so with patients who are also pregnant, we have to screen for TB and make a decision about IPT. So we will arrange a TST in the meantime. If she has no symptoms, we would start IPT on this day if she's not already on it. And then, of course, a lot of this conversation has to start counseling her regarding her pregnancy and HIV, starting to have a conversation around infant feeding and a conversation around HIV. And we want to bring her back fairly soon for all these results. So within 2 weeks, we would like to see her, and she's going to come back when she's 20 weeks pregnant. Great, now we have the 20 weeks visit. She presents, you now have your blood results back, and we see that the viral load is 3,750. The CD4 count is 223. She's got an HB of 9.1. She's TST negative, no TB symptoms, and she claims that she's taking her tablets fairly well. So what do we do at this point? And if you have somebody that's pregnant with a viral load over 1,000, that must be considered an emergency. We need to be able to address that viral load as soon as possible to reduce the risk to the baby getting HIV. So I'm going to go through the mnemonic we've been using in all our presentations on virological failure, and we can use the same in our pregnant woman, which is our ABCD. And A is obviously standing for adherence. In our pregnant woman, remember your mental health issues, look for depression, do your pill counts, check for substance abuse, and of course all the other things that affects adherence, including your stigma, side effects, etc. We want to be looking for other opportunistic infections, and in a woman that's pregnant, very important to ask about STIs. They might not always mention this, but also there might be other illnesses that's interfering. So for example, some women are very nauseous during pregnancy and might be struggling to take her tablets. Correct dose in her case is probably not relevant unless she's got a history of kidney problems. And very important to ask about drug interactions. Sometimes when women are pregnant, they will go and ask for various over-the-counter immune boosters or things they're taking for the baby, or traditional medicines. And of course, we want to get that viral load back very quickly. So the last viral load was done at 18 weeks. We want 2 viral loads that's going to be 4 weeks apart for us to be able to determine on whether this ARVs are actually working. And so your last viral load was 2 weeks ago, and we therefore want to do the next viral load in 2 weeks' time. And you would do that if you think that the adherence is fairly good. Also, we have now a negative TST. She's got no TB symptoms. Hopefully, you've already started your IPT at the last visit, and you can now tell her that she will be getting her IPT for 1 year, and we'll be repeating the TST at that point. When do we bring her back? At 22 weeks. So we want to make sure that these visits follow each other very, very quickly. So today she's coming in for her repeat viral load. What else do we need to do at this point? So check your pull count again. You want to be able to have get a good relationship with her and start having good conversations and a really good feeling in terms of how is her adherence. And today we're obviously going to repeat her viral load. It's 4 weeks since her last viral load at 18 weeks, but also do your baseline test for second line. So we're going to repeat the HB at this point. And if you've not done a hepatitis B at baseline, we will do hepatitis B at this stage. Interestingly, in our pregnant women, we don't routinely do the baseline trigs and cholesterol as you would do for non-pregnant women who might go on to second line, mainly because the pregnancy affects the values and they don't really tell us very much. And again, we want to bring her back fairly quickly for the results of that viral load. So now she's 24 weeks pregnant, and I want you to note that when we first met her, she was 18 weeks. And how quickly time passes now during pregnancy as we try and resolve this viral load. So she comes back for results, and her viral load is 1,250. She's hepatitis B positive, and she has a hemoglobin of 7.8. So how are we going to manage this patient now? Firstly, if you're a nurse or you're a primary healthcare physician that's not very confident about changing to second line, this patient has to be urgently referred on that day to a doctor that can make that decision. And on the referral letter, make sure to write all your blood results, your full history, and to record the ABCD as we've been outlining the adherence, opportunistic infections, etc. But if you're the doctor and you're looking at a patient like that, we have a patient who had a viral load over 1,000 4 weeks ago. It's 4 weeks later, the viral load is still over 1,000. There's not been any significant change. We need to change this patient to second line. And a viral load which is like that, where somebody's well adherent and it sort of hovers in the low thousands, are very, very suspicious of a picture of resistance, and she's therefore a very good candidate for second line. Our other issue there, of course, is that she's hepatitis B positive. So remember, we don't particularly want to stop the tenofovir, as this might lead to a flare of her hepatitis B. And thirdly, she's got quite a low hemoglobin. In pregnant women, if the hemoglobin is over 7, we can still safely use AZT. So in this particular patient, we're going to be using AZT, 3TC, tenofovir, and Illuvia. So she's going to be on 4 different drugs. And very important is to not just assume that hemoglobin is due to the pregnancy. We need to make absolutely sure there's not something else contributing to that very low HB. And we obviously want to give her a return visit fairly quickly. We'll bring her back in a month's time to see how she's doing on that second line treatment. I've added a short slide on anemia and pregnancy, as this is often mismanaged. Very important is to not assume that a hemoglobin that is low is always due to the pregnancy. And TB is the one illness that we certainly do not want to miss. To be able to exclude TB, you simply use your symptom screen. So you check whether she's got any cough, you check whether she's got any fever, any drenching night sweats, and very important, you have to check what's happening with the weight. And in pregnant women, you can also use your MUAC to give you a clue. If you do have any of your 4 symptoms, remember it might not only be pulmonary TB, you also need to look for extrapulmonary TB. So if they don't have a cough, but they've got any of the other symptoms, that is still a concern. And your extrapulmonary or disseminated TBs are the ones that quite often would contribute to anemia. Our definition of anemia in non-pregnant women is a hemoglobin of less than 11.6. But note that we've got a lower threshold in our HIV positive population, and we would use actually hemoglobin of less than 10.6 before we would start investigating. Very important, if you've got that single low HB, to be able to do a proper assessment, do your full blood count and diff, do your reticulocyte count if possible. The reticulocyte count is very useful to start pointing you to a diagnosis. Is this due to destruction of red blood cells, or is this due to a poor production of red blood cells? In patients like HIV and TB, it's quite often due to bone marrow suppression due to the illness, and they would actually have very low reticulocyte counts, showing that not many new cells are being made. And probably the most important part of your testing that's going to give you a clue in your management is your MCV. If the MCV is normal, you can continue your normal prophylactic dose of iron, but it's very important to not treat your normocytic, normochromic anemias with iron. And that is because the iron can both feed the HIV as well as TB. If there's a low MCV, then that confirms that low iron might be part of the issue. And in those patients, you could use your full dose of iron supplementation. And important to check your HB in 4 weeks, and you want to see a good response in that hemoglobin within a month. And that will help confirm that it is the low iron that's contributed to the problem. And of course, once the MCV is recovered, and once your HB is recovering, you want to drop that iron back down to a prophylactic dose. So let's get back to our patient who's now 28 weeks pregnant. She's been 1 month on second line. She's got no complaints. She has no side effects. And so when do we do the next viral load? And actually the guidelines is not clear about what you do once you start people on second line. If she was not pregnant, we would normally redo the viral load at 6 months. But certainly in this patient, we would like to know before she has her baby whether the viral load is suppressed. And so we want to see that response. And you want to do the viral load at the latest 3 months, and you want to do it before she has her baby. So in this particular case, we decided that we would repeat the viral load at 36 weeks. If you're quite concerned about, for example, adherence or other issues, you might even decide to do it earlier. So now it's 3 months later. Our patient is 36 weeks pregnant, and we take a viral load today. She's still on IPT. Her hemoglobin is now 9.8. She's had some iron because her MCV was low. And again, we've taken the viral load today, but it's going to take us another 2 weeks to get the results. So always keep that in mind when you put your dates for your viral loads, because all of it leads to further delay. And so she now returns at 38 weeks, and the viral load is 45,321. So what's going on here? And in a patient like this, who's on second line, been on second line for 3 months, the viral load over 1,000, there's only one major concern in your mind, and that is adherence. This patient was changed from a first-line regimen on which she was failing to a completely different regimen. And we would expect our patients to achieve easily full viral load suppression. If a patient is on second line and at 3 or 6 months is not virally suppressed, adherence is by far your first concern. And we need to find out why she's not taking her treatment. And when we check further, we discover that she gets quite bad diarrhea on the lopinavir ritonavir. And so on the weekends when she goes home by taxi, she gets a bit nervous, and so she doesn't take her tablets on the weekends. So what do we do now? Tricky scenario. She's 38 weeks pregnant. She can go into labor anytime. She's already on second line. She's got poor adherence on that regimen because of side effects. She's got a high viral load, which is going to be of great concern in terms of transmission to the baby. And remember, she's hepatitis B positive. So important, we first need to try and address the diarrhea issues. It's important to investigate the diarrhea normally. So usually if you have a patient who's on lopinavir ritonavir or going on second line, you want to make sure it's not an iris. So we'll be sending stool cultures. But in this particular patient, we don't actually have that much time. If it doesn't look like there's any other signs of infection, I would prioritize trying to address the lopinavir ritonavir. And so in this particular case, one might do a straight switch of the lopinavir ritonavir to atazanavir. Remember to do a baseline ALT in those scenarios. And you want to start discussing infant feeding options. She can go into labor at any point. The viral load might very well not be suppressed by the time she goes into labor. And it's important at this point already to talk about formula feeding. And if you are going to consider formula feeding in this patient, to make sure that it's going to be available where she is delivering and that it's very clearly noted in that maternity record. So great, we're now at 41 weeks, and our mom's been on AZT, 3TC, tenofovir, and atazanavir, ritonavir for 3 weeks. Her diarrhea is better. She's now adamant that she is taking a treatment, and she's gone into labor. So what we're going to do today to minimize the risk to that baby. And of course, our normal good practice is no instrumentation, starting to have that infant feeding discussion. So remember, the last viral load that we know is of the one of 45,000, and we can't try and guess what we think the viral load is today. So we're going to manage her as a patient with a high viral load. And so we need to make a decision, are we going to be putting her on the breast when she delivers? If we have formula feed available and we can reliably provide her with formula for 6 months, formula may be the best option at this stage. If not, we might very well have to opt for breastfeeding. Because that last viral load was high with the baby, we're obviously going to do our routine birth PCR, but this baby will qualify for AZT and nevirapine for 6 weeks. Not only because the viral load is high at the moment, but remember this mom's on second line, so she already has resistance to efavirenz with a good chance of cross-resistance to nevirapine, and we're adding an AZT to make that regimen a bit more robust. She's also hepatitis B positive, so to cover the baby, we need to provide the baby with hepatitis B immunoglobulin and to give the first hepatitis B vaccination dose. Our mom has been on this new regimen for 3 weeks now. So 3 weeks ago, we switched the lopinavir ritonavir to atazanavir ritonavir because of the poor adherence of the side effects. So we would again want to get 2 viral loads 4 weeks apart to make sure that she is now suppressing. So we would be redoing this mom's viral load in 1 week time. So now our baby is 1 week old and our mom has been on this new regimen for 4 weeks. Our baby's followed up at the hospital and the birth PCR is negative. And today we're doing the repeat viral load of the mom. Remember, we also need to monitor that HB because she's on AZT. And we're going to ask the mom to return when her baby is 3 weeks old. So that's 2 weeks from now, so we can see what the viral load result is. When they return, when that baby is now 3 weeks old, the viral load come back as 3,231. So just remember the last viral load was 45,000. And that means that this has been more than a log drop in 1 month's time. So that shows that the adherence has certainly improved. She's taking a treatment and that the treatment is working. We're still going to keep an eye on it to make sure that viral load is going to suppress, but we're comfortable at the moment that we're on track. We're going to continue the AZT and nevirapine for that whole first 6 weeks. And we're going to repeat that viral load when the baby is 5 weeks old. So remember, we did the last viral load when the baby was 1 week old. So again, it'll give us a 4-week stretch to find out whether that viral load is finally completely suppressed. So now our baby is 6 weeks old and they return to the clinic. We've got the viral load result back that we did at 5 weeks, and the mom's viral load is now 68. The mom's been formula feeding and the baby as well. So we're going to stop the nevirapine and AZT today. She's had her 6 weeks of post-exposure prophylaxis. She's formula feeding. But even if she was breastfeeding, with that viral load that's now suppressed, we can stop the nevirapine and AZT at this point. There's a question here on whether we would want to reintroduce breastfeeding, and that is possible at this point. It will take quite a bit of support and counseling to help reintroduce breastfeeding. And that will depend on your ability to provide reliable formula feeding until the end of the 6 months. We obviously want to start our baby on Bactrim today and start with our first immunizations. Remember to do your follow-up hepatitis B or second hepatitis B immunization. And the mom needs to have her pap smear done and contraception. We no longer do a PCR at 6 weeks. Remember, the baby's been having nevirapine and AZT at 6 weeks, so even if the baby converted, the viral load might be suppressed in the baby, which might give a false negative PCR. So we're going to do our PCR once they're off prophylaxis for 4 weeks, and so that will be done at 10 weeks. Thank you very much. Please do see our other modules on complicated cases. There's one at the PMTCT series on TB and HIV. And there's another case on pregnant women and STI.